microphone. All right, so I trust you had a great lunch. I was just excited about the first case study from Oregon, who, you know, shamelessly, they're icons to me. Everything they do in Oregon I like, so I'm easy. But I hope that you'll have good questions and you preserve those questions. So our second case example on health and education collaboration to improve specific outcomes, educational outcomes, is from Cincinnati. You're going to hear from two speakers for this case study. First would be Robert Kahn, who is a professor of pediatrics and serves as associate chair for community health at Cincinnati Children's Hospital Medical Center. And on the phone, we have Kotagal, who is the executive leader for population health and community health and senior fellow for Cincinnati Children's Hospital Medical Center. So we're going to start with Robert and hold your questions, and we'll have time for questions for both panels after their presentations.
Great, thank you very much. And I'm going to go ahead and do the slides. Uma couldn't be here in person, but she'll come in with color commentary as needed. So thanks so much for letting us speak today. I'm going to try to hopefully echo a few of the themes that you heard earlier and sharing the work of the folks up on the screen right now. So I just want to give a shout out to the superintendent of Cincinnati Public Schools, Laura Mitchell, Cheryl Broadnax, the assistant superintendent, who was really the lead innovator in some of this work starting about 2 or 3 years ago, Uma, who was just introduced, and then Christina Harding, who's one of our senior quality improvement folks. And what we want to share with you today is a little bit of the how of what we're doing in healthcare and sharing it with the school system. So less of a what, not about direct service delivery, which we also do with the schools, but really focus on the how. And as we describe that work, hopefully some of the themes that were touched on this morning, like what about shared outcomes, the fifth vital sign? What about multi-level leadership? What about the multi-sector work, and how do you get that done effectively and efficiently with synergies? What about parents? What about the need for connective tissue? I hope you'll see that sort of woven through what I'm going to talk about now. They're pulling back up the slides that I can see, but I'll turn my head as needed. Hang on. There we go. So what I hope to address... Hang on. What's that? Uma, you there?
Yep.
Okay, great. Sorry, I got to get used to the clicker here. I practiced earlier. All right. Here we go. So hopefully we can address 3 questions. Sort of why is healthcare working with education? Why have we chosen to work with education? And the how we are working, and touch on our strategic plan of the hospital. What are we bringing to the effort? And I'll describe a little bit about the quality improvement, training, coaching, and tools that we're bringing, and then how is that being applied? So just touching lightly on several key topics, outcomes of reading, behavior, sort of a school system-wide approach, and then a little bit about co-production with parents, just to illuminate the how I'm going to talk about. So here's the why is healthcare in this space, right? So Cincinnati Children's Hospital is the provider for 95% of admissions in our county. It serves an 8-county area. And its vision statement is to be the leader in improving child health. And we've had a visionary set of CEOs and board chairs who, for our 2020 strategic plan, said, what does it mean to improve child health that goes beyond health care? And among the 5 pillars in the 2020 plan was specifically one for the first time on equal standing around community. It's stated as help Cincinnati's kids to be the healthiest in the nation through strong community partnerships. And that health and that partnerships piece was really important in giving the board confidence to move out of our usual boundaries in the exam room or in the hospital. That this was only going to work if we figured out the community partnership piece. So how did that get played out? So we had to draw a circle. We said 66,000 kids. So that's the geographic region of Cincinnati. Obviously, in our 8-county market share, it's much larger. At the county level, it's 187,000 kids. But trying to maintain a space in which it was both real and doable, but small enough for learning. And we had to come up with some specific outcomes to bring this alive. So we had 4 outcomes in 2 buckets. So 2 of the outcomes around morbidity and mortality, and 2 for the first time really pushing what does it mean for kids to be healthy and thriving. And so in the morbidity and mortality space, we focused in the strategic plan around reducing annual infant deaths and reducing the disparity in hospital bed days, focusing on 2 high-risk neighborhoods. In the thriving space, we focus on what does it mean to have kids have a healthy mind and body at age 5. And then this 4th one is the one we're going to focus on today, but I wanted to give you the context of where this sat in an overall hospital strategic plan, which is in partnership with the Cincinnati Public Schools, increase the percentage of children who are reading proficiently or above by 3rd grade. So we also wanted to share a little bit of how we're organized so that the rest of the talk makes sense. So we created something called a learning network based on what we had learned through other learning collaboratives and extensions for chronic disease. And the way ours got set up is around 4 outcomes. So you see the infant mortality, the bed days, the thriving at age 5, and the 3rd grade reading. And we created improvement teams to help drive that work. These are not coalitions, they're not endless meetings. It's really who wants to work on those outcomes, who wants to test daily, who wants to embrace early failure, who wants to share a mindset, an outcome, a theory with others, rather than let's get everybody in the room. So we created 4 improvement teams. You see that lower one is around social influences in the neighborhood. So we wanted to be very explicit about some of the root cause work we talked about earlier today. And for the 3rd grade reading, and for actually each of the teams, we have community co-leads. So the assistant superintendent is the leader or co-leader of the 3rd grade reading improvement team. And then we have a series of cores we're using to support the work of those improvement teams. So the top one is community quality improvement capability, and so on, as you see down below. And what we're going to, again, focus on for the purposes of today's meeting is really the 3rd grade reading outcome, the 3rd grade reading improvement team, and this use of QI, most importantly, as what we're trying to bring into the education space. So what are we sharing? And again, Uma taught me this early on, like the educators are the content experts. We are not the what, but we learned a lot about quality improvement from Toyota, from nuclear industry, from other industries in trying to do the safety work. And again, Uma led a lot of that work starting about 20 years ago. So what could we draw out of that space and then share with this public school? So we're sharing theory, we're sharing small-scale rapid testing, we're sharing a little bit about how we implement, and we're sharing how we think about population segmentation and data over time, and I'll give examples of each of those. The how are we sharing it, I won't spend time on, but we can talk about it later. We support a series of courses and training, some of them in partnership with our local Strive group. We do consultation and coaching, and we have larger learning sessions. So again, in sharing these methods, there's a pretty structured way in which we go about sharing it. So as an example, here's the theory piece. So we use something called key driver diagrams. Is anybody, it's like a logic model. I think some people familiar with key driver diagrams? Good, there's enough familiarity. But basically for us, it's a way of being explicit about theory and then testing against it. So what you're looking at here is actually the assistant superintendent's key driver diagram that she has continued to modify over time. It's got a global aim, it's got a smart aim, it's got a forward-looking 2020 aim, and then the primary drivers that she, through her work with the frontline teachers and reading specialists in the school, think have to come together to get to success around that reading goal. And a few of the very active ones are highlighted in green, like consistent evidence-based instruction in foundation literacy, population segmentation and use of valid, reliable data, healthy emotional, physical, and mental domains for the kids as examples. There is a 3rd column, then are a series of very explicit interventions that are going to be tested against known drivers. So again, to this notion of many, many programs, but if they're not consistently linked to our theory of what's driving a very specific outcome, you can get that overwhelmed feeling, whether it's in healthcare or in education, that we're doing a lot of things, but I don't know what it's linked to and is it moving the outcome. So we've shared a lot about theory. We've shared about small-scale rapid testing, the model for improvement. Hopefully many of you are familiar with, right? 3 simple questions. What are we trying to accomplish? How will we know that a change is an improvement? What changes can we make that will result in the improvement? And then that leads to a cycle of planning, doing, studying, and acting. And the teachers are actually fabulous at this. They're far better at it than many of the physicians and nursing teams we see in the hospital, right? Making a prediction, understanding what happened, was that part of the plan, comparing results against their prediction, and then adapting, adopting, or abandoning it. And what we hear consistently for the teachers is in education, very frequently, it's a new curriculum. And then you lay out 9 months worth of work that somebody else has told you it's going to work, and you don't find out until the proficiency results sort of come out the following year, and the wins around a particular curriculum change every few years. What we're really encouraging them to do is each week be very explicit about what you want to test and how will you know if it's working. And the data doesn't have to be perfect. It doesn't even have to be right. It just has to be useful. So if there's it reduces sort of the fear mode in testing if you're trying small things more rapidly. Another area we've helped them with is how we have implemented in the hospital and how does that translate into the school. So the hospital often uses something called a huddle, where each day, in a highly structured, highly efficient manner, you cover key points. So there's a safety huddle for 30 minutes at the start of the day. What we learned is the teachers have rare opportunity to learn from each other, right? So 30 minutes each week, it's an all teach, all learn environment. What one teacher is finding is working and another one can quickly spread to the other teachers who are on the call, or if there's a complete fail, there's no reason the 38 other elementary schools should try something that 2 or 3 teachers have already found don't work. So it's a time to learn and problem solve together, crowdsource the right ideas, safe space to share successes, and it seems to bring a tremendous amount of joy and learning through the social connections. I've personally heard at least 3 very experienced teachers and administrators say in their 25 plus years of teaching, this year has been the best year of their professional life. I think the other piece is being customer focused, and what Cheryl and her team really wanted to do is engage the students. So what you see here is a picture of their Plan, Do, Study, Act on the wall in the kindergarten and first grade classroom. And then there was just this really cute example. They did Mardi Gras beads in which the kids own their own goals. And on Friday, if they met their goals, or whatever the subunit of the curriculum was, they get to wear a badge that says, I met my goal today, ask me about it. And the incredible pride of the kids in owning and actually putting up on the wall their version of the goals. Finally, in terms of elements of the quality improvement, this notion of population segmentation and trajectories. So what you're looking at here is the 3rd grade proficiency results yearly from 2005 onward. And it's very hard to learn quickly in complex environments if once a year you get results sort of 9 months after the school year ended. And taking and building on their notion of proficiency and on track and below to sub-segment a little bit more, how can they look at more actionable data in segments of the classroom. So if you have 30 kids across a couple domains, so here it's the measure of academic progress and the DIBELS, this notion of going from once a year proficiency to what segment is this kid in, and how do I help them move to the next segment of proficiency? And what you see there on the right then is for a single school, all the 3rd graders mapped over time, and really helping the teachers think about how many kids were in segment X and did I get them up to the next level, and what's the special attention and personalization kids in a particular segment need. All right, last one, I guess actually I'm going to show you. This is classroom behavior. I touched on it a little bit earlier. When things are really complicated, how do you learn? And we find that healthcare assisting with behavior in the classroom is one of those zones. So what this is a single kindergarten child, and the y-axis there is the number of interruptions. And the teacher was so excited to partner with a pediatrician live on a daily basis that she bought a little clicker off Amazon and was counting the number of interruptions a day. And what you see here then is the child is started off suspended. My pediatrician, Courtney Brown, who's led this work, connecting to primary care, starting meds, missing appointments, moving the medication administration to school, and sort of doing this with a very active dialogue between the teacher and the primary care and the physician and the mother throughout. So this notion of learning from one, and you can only begin to imagine how many fails are identified as you walk through this. You know, from the child had been previously seen by psychiatry or development, or the mom's own mental health issues came up repeatedly throughout, and really learning, not coming in with a program, but saying we have to design this from the ground up from real life challenges. this now is this, so the superintendent got more and more interested. She actually took our intermediate improvement course and is now having her entire leadership staff enroll over the next year in our improvement courses. So this is now at a system level, so much as Uma helped design the hospital's big key system drivers for the entire hospital, Laura Mitchell is now thinking about that for the entire Cincinnati public school system. And off to the right, you see sort of the headers for the big sets of outcomes she has. So instructional outcomes, managerial outcomes, experience outcomes, and talent management outcomes. And her, for example, her head of HR just finished our course, and his experiential learning project was reducing the number of errors in paychecks for teachers. Like, we can't ask teachers to do one more thing if we can't get them the right amount of money at the right time. And having a head of HR show a short chart of how he reduced errors from almost 30 per week to like 4 per week is very profound. Last example of application that I just want to touch on is this co-production with parents. And it's come up today that healthcare and education can only do so much, but we have to engage the parents. So one of the areas we've worked in the low-income neighborhood right behind the hospital, among the most toughest neighborhoods in the city, incredible passion and motivation of parents and grandparents and pastors. And we're working with them to collect their inherent motivation, co-produce solutions, and organize a network of family leaders. And what you see to the right then is the number of Avondale parents who have agreed to read to their children 2 times a week. There's now sort of a snowflake organized model of parents and grandparents who are organizing the measurement and really driving it because they were the ones who said, we want our kids ready to read at school. I think the last slide are the takeaways. So key learning. So metrics of child thriving have to be added to our deficit metrics, right? It can't be enough that babies don't die by age 1. That this learning network has accelerated the cross-sector work by a focus on shared outcomes, a focus on shared methods, a set of core supports. It facilitates the cross-sector effort. The integration across the sector should be real and realizable. It can't be undoable and everybody loses faith. It can't be, we'll see a result in a year, and people drop out of the effort. The improvement capability building provides a common platform for measurement, testing, learning, and creating that new system. And the only way to get all these sectors aligned and all these programs aligned is to do the co-production with parents, because then you're solving for the path of a child and his family, as opposed to optimizing my clinic or the school nurse's room or the elementary school teacher's room. And finally, that joy in work enables resilience, right? To have these teaching professionals or the healthcare professionals say, I've never had a year like this, gives everyone sort of the courage to keep going on. So I want to pause there and give Uma, if she's unmuted, a chance to chime in, since I'm sure I missed it, and she's got so much wisdom in the space. Uma, are you tied in?
Rob, you're never disappointed, so thank you for allowing me to join. I think I was going to mention that 3 important issues that we face. One, I think, is data, and I wonder if you could speak about data, because our data in the classrooms and in education is often annual or biannual, and we're trying to use data that may be reflective of progress on a daily basis. The second, I think, is the role of partnerships, the respectful mechanisms by which we learn to value each other. And this, I think, is a fragile but very important piece when we're working across, sectors. The third is the different levels of the data at which we intervene: the school level, the classroom level, and the student level, and how do we keep track of interventions in each of those areas that could influence the work. And then finally, I think using the N of 1 charts to learn faster about what's happening. I also wonder if you could mention a little bit about the good behavior game and some other mechanisms that we're trying to test in organizing. One important learning for me has been around dosage, so I wonder if you could say a little bit about that.
Great. Maybe I'll just start at the end, and maybe we'll come back to the data, because I think there were some shared data questions earlier. I think on the behavior piece, there's clearly a how and a what for us. So the challenge is there's so many segments of behavior that could be addressed, right? So Uma mentioned the good behavior game. that's a universal approach, a pro-social approach that lifts all. So in Columbus, there's 35 schools implementing the good behavior game. They've reduced all sorts of disciplinary infractions. All the way on the other end, we have the head of child psychiatry placing, his MD psychiatrist in certain spaces in the school that often ends up in a medication approach. What we're really trying to do now is simplify and come up with a population frame, right? So in a classroom of 30 kids, how do you weave together the positive behavior work, maybe the early intervention and trauma-informed care work with the actual medical care? We brought 7 folks up to a school district up in Wisconsin where they're really focused on quality improvement framework and results orientation with behavioral health, because we really all need to come to the school with the same mindset. So we're hopeful that over the next year we can bring this all together. What the superintendent has asked is to develop 6 prototype elementary schools to go from K through 6 and put all of this together. So not just third grade reading, not just behavior, but what would it take for both math and reading outcomes and pro-social and behavioral health all coming together in the schools. And that's why, to Uma's point, it's not enough to just work at the classroom level, but to get the principals on board, then we need the superintendent on board as well. So trying to work at a variety of levels. We haven't figured the data piece out fully yet, or the data platforms, but again, we're always looking for innovation if others have suggestions or good examples. So I guess we'll stop there.
Oh, okay.
Does that sound good? Questions? So we're going to wait on the questions,
I
right?
didn't know if
Uma, any other final points you wanted to make?
I think one thing we notice in the classrooms is, although the teachers have good intention, that the dosage, and I call that word very loosely, dosage of the interventions is pretty chaotic. So the teacher could go for an entire week without paying attention to one of the children that need her intervention, because the classroom itself is a little bit chaotic. And we found that individual teachers and individual reading specialists can vastly improve that just by some amount of paying attention and having these individual charts that allow them to know that these kids, got it. Sometimes we're finding in some of the classrooms that the kids only 40% of the kids or 25% of the kids who need an intervention from a reading specialist, let's say 4 times a week, actually gets it. So there is a big issue of reliability of these interventions, and both in the classroom level and at the school level.
And we've used that dosage metaphor to help sort of bridge between healthcare and education. The notion of, in absenteeism, you're getting a 0 dose. If you're there but you have ADHD that's poorly controlled, you're getting a subtherapeutic dose. If you're constantly interrupted and pulled out of a classroom and bathroom breaks and noise, you're also diminishing the dose. It's almost a version of the quality life years, I think, Bob, that you raised earlier, that all of those things pull mind or cognition away from a focus on the teacher. Great. Thank you all very much.
Thank you, Robert.
Thanks.
Okay, let's see.